Welcome, everyone. I'll just give everyone a few seconds to start joining the webinar. Amazing. Looking like we got a number of people already coming in here. Fantastic. Alrighty, well, without further ado, we'll get ourselves started here. My name's Troy. I'm the Director of Operations of Nurses Specialized in Wound, Ostomy, and Continence Canada, and I'm happy to be on with another webinar here. This time, we are so thankful to have the support of Integra Life Sciences, who are making this education today possible. And we have a guest speaker with us, Dr. Jeffrey Jensen, who we'll introduce in just a moment. Before we get started, I'll do a little housekeeping items and a little icebreaker, which you know I love to do. If you can just pull up your chat button in your Zoom toolbar, let us know where you're tuning in from. I'm tuning in from Ottawa, Ontario, and I know we're going to have tons of people from across Canada, maybe from the States as well, and even abroad. Lovely, got people from Peterborough, from Toronto, Windsor, Prince George, Winnipeg. Fantastic. So as you all know, we will be having a Q&A portion later on in this webinar. So you're going to be using that Q&A button in your Zoom toolbar. At certain points, Dr. Jensen may ask you to use your chat as well. So make sure you got both of those handy as well. Today's webinar is being recorded, so you'll be able to watch this after the fact or share with your colleagues if they do need to go and take a look at it. And you will be receiving a certificate of attendance. So just stay tuned for a couple days after the webinar. We'll get that to you. So without further ado, I'm really happy to be introducing our guest speaker for today's topic on Healing is Believing, a closer look at the real-world applications of total contact cast system in offloading diabetic foot ulcers. Dr. Jeffrey Jensen is currently a dean for the Arizona College of Podiatric Medicine at Midwestern University in Glendale, Arizona, and also serves as the chair of the American Association of Colleges of Podiatric Medicine. He's board certified by the American Board of Foot and Ankle Surgery and also co-founded the North Colorado Medical and Surgery Residency Program. As an active researcher throughout his career, Dr. Jensen has generated over $5 million in research grants from the National Institutes of Health, the Department of Defense, and state organizations. And this research has resulted in 14 patents for products addressing diabetic foot wounds, fractures, infections, and preventing head trauma. Dr. Jensen created the TCC EZ, a total contact cast system that is utilized to assist in healing diabetic patients with foot wounds around the world. Dr. Jensen is also the host of the Dean's Chat podcast, which can be found online at www.deanschat.com. So without further ado, I'm happy to pass the mic and the screen sharing over to Dr. Jensen. Thanks, Dr. Jensen.
Thank you for that introduction, Troy, and I appreciate the invitation to join all of you today. It's ironic that this is a Canadian audience because I just got back from an opening weekend fishing trip in Ontario, and we just had such a great time and caught a lot of northern pike and walleye. But here I am in Arizona. It's 105 degrees, and I'm glad to be with you today. So thank you again. Make sure this is working. There we go. Before we get started, I just want to give you a disclaimer. As Troy mentioned, I invented the TCC EZ cast. We put it on the market in 2008, and Integra owns the cast now. And since 2017, and I really have to hand it to Integra. They've just done a wonderful job marketing the cast. There have been over 300,000 applications of the TCC EZ on diabetic foot ulcers and acute Charcot joints, and also used postoperatively. So they let me still come on and give some talks once in a while. So I'm really excited to be with you all today and representing Integra, but also represent as a clinician, also representing the TCC EZ for optimizing offloading in diabetic foot ulcer patients. So I'd like to start off with this slide. It's leaders do the right things and managers do things right. We're all leaders, right? We're all leaders when it comes to driving the ship, if you will, when we're treating patients with diabetic foot ulcers. And one of the things we need to do when we lead is we need to take into account the most important aspects of healing, which include addressing vascular concerns, infection concerns, and offloading concerns. And doing the right thing is so important for our patients. So I think you're going to appreciate the discussion around this concept. I do a lot of presentations on TCC EZ, and a lot of the discussions are around these 7 bullet points. Total contact casting challenges, if you will, points of pain, if you will. One is accessing the EZ cast. The second is patient concerns. The third is clinician concerns. The fourth is clinic concerns, such as timeliness and flow of patients. Financial concerns. and then application and removal concerns. So if you can, while I'm going through the talk, if you've got some specific questions, please put them in the chat and we'll discuss it at the end. I'll be very cognizant of time today. My discussion will be about a half hour worth, and then we can have 15 minutes or 20 minutes of discussion around any questions that you might have afterwards. So the first thing I wanted to talk about, because I've already touched on them, well, we are very fortunate in the wound care space that we have consensus documents. Consensus documents came into vogue in about 2012, and you've got consensus documents around peripheral vascular concerns, which are essential for healing. You've got consensus documents regarding infections and the appropriate way to treat infections in the diabetic foot. And then interestingly enough, there's another big area of consensus documents around offloading. And for these reasons, the reasons that I've just discussed, these are considered the VIPs: vascular, infection, and pressure relief. You know, it's offloading, but it doesn't fit into a nice acronym, so we'll go with pressure relief. So you all are familiar with treatment priorities, right? At the top of the list, top priorities: if there's an infection, if there's vascular concerns, we're admitting patients to the hospital, we're debriding those wounds, we're bringing in our interventionalists or vascular colleagues to help put more blood into the foot. Once all of that's controlled, we fall into what we do in an outpatient arena, okay? We debride the wounds appropriately. We offload them appropriately. We educate the patients so that they're on the same team with us, so we're getting the outcomes that we desire. There's blood sugar control issues. Of course, if we had glucose control issues intact from the minute they were diagnosed with diabetes, we wouldn't have the neuropathy, and henceforth we wouldn't have the wounds. And then, as you all know, the wound environment is so important. There's so many ways that we can enhance the proliferative phase of wound healing through technology and products and bioscaffolding and bioengineered tissues, growth factors, but we don't always need those, right? I mean, if we're in a situation where we've got a good blood supply and no infection, and there's a plantar wound that does not go deep to tendon, bone, or capsule, after we debride that wound, we can offload them and get to heal in a timely fashion, and that's what we're going to talk about today. One of the reasons the VIPs is so important is because our patients present to the clinic with so many different presentations. There can be infections, there can be burns, there can be severe vascular issues. There can be Charcot joints with bony prominences, as you see on the top next to the left. On the bottom right, second picture in, these are patients that had burns from walking on very hot concrete in Las Vegas, Nevada. Patients, because they have neuropathy, have no feeling. So one of the most important things we need to understand from the beginning, and I know I'm speaking to the choir here, is our patients don't have feedback. They don't have feeling in their feet. So it's not like an ankle fracture that I get called into the ER and I go and see, and the patient's in significant amounts of pain. And I suggest treatment, and it might include a cast if it's a non-displaced fracture. They want that cast because they're in pain. And when they ambulate, they have pain. That's not the case for our diabetic foot population. Our patients do not have feeling. So it really heightens the need for education from the clinician's perspective and really getting the patient on board with your treatment plan. Little background on me: I ran a wound care center in Denver, Colorado for 17 years. We put on between 800 and 1,200 total contact casts a year. I've trained over 8,000 physicians and healthcare workers on applying TCCs. I put this picture in because this is the first cast I ever applied, the one on the right. It was in 1992, and it was when I was a resident in Michigan. Offloading has come a long way, right? I mean, the TCC EZ has really made offloading easier for what we consider to be the gold standard. How are we going to put a non-removable device that will allow a patient to ambulate and heal at the same time? And we'll talk about that as we go forward. So indeed, appropriate offloading is the difference between a patient with a very straightforward wound, as you see in this picture, second metatarsal head ulceration. That wound is either going to heal in a timely fashion or it's going to get infected, one or the other. Those are the two options. And our plan, why we use total contact casting, is it provides an ability to let the patient ambulate and heal at the same time in an outpatient setting. I should note that total contact casting is a little bit of a misnomer, if you will. It's really an ambulatory total contact cast. That was originally why it was invented on patients with leprosy and brought to the United States of America by Dr. Paul Brand, to let patients ambulate continue to be included in everyday activities, but heal at the same time. So I'm going to show you a few slides on some stats. I think bringing evidence-based medicine into play is so important. All of us were caught off guard in 6 years ago when in diabetes care, there was an article that stated after years of decline, amputations increased by 50% between 2009 and 2015. That's a scary statistic. In the United States, we have 2,000 wound care centers. We have all these advanced products. We have all these specialists. But what's going on here? What are we missing? Are we missing the VIPs? I want you to remember these dates, right? 2009 to 2015, because I'm going to reference back to that in another study in a little bit. Two other studies, very important. Pecoraro and his team back 30 plus years ago showed us that 84% of amputations are preceded by a diabetic foot ulcer. This is self-evident. We knew it, but it had never been documented before that time. So it really truly becomes a race. Are you going to heal that patient, or might the patient get infected and lead to an amputation? And that was substantiated 15 years later. Again, in this case, it was Dr. Lavery and Dr. Armstrong. 50% of all diabetic foot ulcers get infected. It's incumbent upon us as healthcare professionals to give the patients the best chance we can to get them to heal as quickly as possible. Because if they get infected, you see the second bullet, 20% of those that get infected receive an amputation. So we don't think of this as being a North American problem, right? I have traveled all over the world and I've taught offloading, and we've seen significant advances in increasing the peripheral status of blood supply. We've seen lots of advances in antibiotics for infections, but we haven't seen a lot of advances in wound care for offloading. So I've trained docs in Brazil, England, Ireland, throughout Europe, Japan, Australia, in the US and Canada. And the biggest challenge that I see when I go into these clinics and I see patients with these docs is that they're not offloading these patients appropriately. And because of that, the race between healing them and them getting infected and potentially having an amputation comes into play. We need to heal these patients as quickly as possible. All right, remember the dates I just showed you. So, it was 2009 to 2015. This is very similar. This is data. This is 5-year data between 2008 and 2013. And it's from the U.S. Wound Registry with Dr. Caroline Fife. And the title of the article was Diabetic Foot Ulcer Offloading, the Gap Between Evidence and Practice. And I'm not going to go through every stat here with you. These are all straightforward. But what I do want you to look at is there were 12,000 patients, over 25,000 diabetic foot ulcers, but there were almost 250,000 clinic visits, right? 221,000 clinic visits. And the question that was asked was, what percentage of these patients had offloading documented in the chart? And offloading is a loose term, right? That could be a post-op shoe, which is, we all know doesn't work. It could be a removable cast, which we've seen many studies that show. In fact, the study came out in 2021 that showed that if patients wear a removable device, they only wear it a third of the time. And that was replicating Armstrong's study from 2000. So of this 250,000 visits, what percent do you think had offloading documented in the chart? And the answer is 2%. Now, when I ask this question, when I'm going around the country, even around the world, I will oftentimes get answers of 75%, 50%, 25%, but the real answer is only 2%. 2%. So of the 221,000 visits, less than 5,000 had any offloading even mentioned in the chart. And what's really sad is that the post-op shoe, which in no way, shape, or form has ever been designed to treat a diabetic foot ulcer, was the most common used device for offloading in about approximately 37% in this study. I used to do 400 surgeries a year. I use post-op shoes every day for my surgery patients. We did not use those for diabetic foot ulcers. We put those patients in total contact casts. So from the consensus documents, 2 statements I like to quote. One is from Ostomy and Wound Care 2010. From a practical standpoint, widespread adoption of effective offloading modalities makes the most improvement in healing. And then from the JATMA article in 2014, and I was actually part of this group, total contact casting is the preferred method for offloading diabetic foot ulcers, and it consistently demonstrates best healing outcomes and is a cost-effective treatment. So here in the United States, hospitals are getting reimbursed. $1,000, $1,500 per treatment of advanced tissues, growth factors, for example. And total contact cast, a cast costs $120 to apply. And if we can heal patients with 6 or 7 casts, that's just a tremendous return on investment for what we see in terms of healing and in terms of quality of life for patients, which we'll talk about in just a minute. So if you look at studies that have been done on total contact casting, we can typically see 90% of the patients heal in 5 to 8 weeks. If you look at a meta-analysis, which is an evaluation of all the studies, and you gather the data together, 88% of the patients that were total contact casts heal in an average of 43 days. So this is significant, and it really does take into play that race we just talked about between, is the patient going to heal or are they going to get an infection? So the whole reason total contact casts work, whether they're traditional casts, and as you may know, Integra has the MediCast, which is a replica of Paul Brand's original total contact cast. It involves plaster, it involves fiberglass, and it has a heel peg, or the TCC EZ, as you see on the right. The whole concept is that we're going to eliminate as much as possible ground reactive pressures on the bottom of the foot and thereby reduce shear stresses. It's the shear stresses that we need to control, because direct pressure doesn't get in the way of epithelial tissue migration, but direct pressure with any horizontal or transverse pressures at all will decrease the ability of the epithelial tissue to migrate over the wound. So I have a little video to show you. A picture is worth 1,000 words. I don't know how many a video is, but this is a great example of a patient wearing a cast. It slows them down. They cannot propel off their midfoot or forefoot. So most of the wounds we see, in some studies upwards of 85%, the wounds occur on the forefoot. But if you lock the ankle at 90 degrees, the patient cannot propel themselves forward. So you significantly decrease the pressures on the bottom of the foot. So for example, there are studies that showed pressures on the bottom of the foot are as low as 0.35 newtons per square centimeter. It's just amazing how it can be completely offloaded while the patient's ambulating. So reducing ground pressures and shearing forces is so important, and that's what the total contact cast does. So I wanted to share a study with you that was comparing the traditional cast to the TCC EZ. This came about right around COVID time. It was out of Texas. You'll recognize the names, Dr. Wukic and Dr. Lavery, amongst other members of their team. And I wanted to emphasize the fact that when I developed the TCC EZ, I did it with grants. I did it with grants from the National Institute of Health. And I also took in some of the technology that we developed through the Department of Defense to help injured soldiers self-rescue. And so what you see in the TCC EZ was designed to offload as well as a traditional total contact cast. So I want to show you the results of this last study. This was published in 2020. And again, like I said, it's got some significant names. I'm going to give you the highlights here on the next slide. I'll read the abstract a little bit, but they acknowledge that a traditional total contact cast is indeed the gold standard. And they also acknowledge that the prefabricated kits, such as the EZ, introduces a user-friendly casting process. And really, that's why I invented the product. I knew that if I could get the TCC EZ into clinicians' hands and they found it easy to use, that more patients would get the TCC EZ cast or total contact casting in general. In fact, some of the studies have shown that 4 times as many patients receive total contact casting if the EZ cast is implemented in their clinic. But back to the study. So they wanted to see pressure distributions and cast weight, which are two of the most important things that we deal with compliance. It was a study using a treadmill, and they had 9 males, 6 females, and it was 30-minute walking trials. And what they found on the right side, significant data, was the peak pressures and the pressure distribution was favorable with the EZ, even compared to the total contact cast, which I found to be surprising. But what's really interesting is the patients found the TCC EZ to be lighter, and because it's lighter, they are more willing to wear it. And as you know, it's got the honeycombs in it. It's breathable, so it's not as warm either. So this is a good study, just looking at comparing the 2 types of casts. My favorite study of all time is 20 years old. Dr. Alberto Pagliese, he was the author on the study. They were looking at what's going on at a histopathological level for diabetic foot ulcers. And what does that mean? It means when wounds are healing or being treated, they were doing biopsies of these wounds, and they were looking at characteristics that we typically see with healing. So I want to show you on the next slide. This study involved 20 patients. There were 10 patients in each group. Here's a picture of me with Dr. Pajasi and Dr. Freiberg at the Diabetic Desert Foot Conference in Phoenix a few years back. But what they showed, and this is my favorite slide, they showed detrimental features that we see in inflammatory phases of wound healing. And they also measured beneficial features that we see in the proliferative phase of wound healing. So needless to say, what are we looking at? Hyperkeratosis, fibrosis, inflammation, and cellular debris. We don't want those features. But what are the beneficial factors? Healthy granular tissue, cutaneous annexes, otherwise known as epithelial tissue migration from the periphery, and capillaries forming within the wound bed. If you look at the control group, you can see the crutch control group has a significant higher level of everything that we see in the inflammatory phases of wound healing and in non-healing wounds. If you go to the third column, you go to the total contact cast, you see a significantly higher level of the beneficial features that we see during the proliferative phase of wound healing. This is probably the best study that's ever been done showing at a cellular level exactly what's going on when a patient's wearing a total contact cast versus when the patients are traumatizing their foot in a removable device or a post-op shoe or a crutch-controlled environment. So this is an example. This is an example of a patient. This is one of my patients, a Charcot foot. You can see the patient on the picture on the left is the initial visit. It's even before a debridement of the periphery. There was adequate blood supply. There was no infection. This patient needed offloading and they needed debridement. So I debrided the wound. The picture you see in the middle is the foot 2 weeks later as it starts to migrate. The healthy tissue. The picture on the right shows you a classic example of what a proliferative phase of wound healing looks like. It's a healthy wound base. You can see the epithelial tissue. If you were to pretend that's a clock and you looked at like pretend 3 o'clocks on the far right, 6:30s on the bottom, that glaze you see is not biofilm. That glaze is the leading edge of epithelial tissue. It is so fragile. If the patient were to, in the clinic, say, hey, Dr. Jensen, I have to go to the bathroom, and they stepped on that foot 10 steps across the hall to the bathroom, all of that healing that took place that week would be eliminated. Hence the need for effective offloading over a period of time. So I love showing this slide because every time I go to Italy, I stop in to see Dr. Pajasi and go to his clinic, and we always go out for good food and drink. But I was asking him on the top left picture, I said, why'd you do this study? And he said it was because back in the early 2000s in Europe, the treatment for diabetic foot ulcer was to do an amputation. And Dr. Pajasi set out to show clinicians and hospitals and the healthcare systems in Europe that indeed we can treat these patients and they have the ability to heal just as any other patient would if we take 3 things into account: adequate blood supply, no infection, and effective offloading. The picture on the right was taken just before COVID. Dr. Pajasi was the president of the European Wound Management Association, EWMA. You're probably familiar with that. And he was talking at that time about the different presentations that we see. And as I showed in that one slide, they're so vast. And we have so many different doctors and nurses treating wounds. We all need to be on the same page with working these patients up to ensure they get what they need. So again, I designed the casts for clinicians, for more patients to use. The cast attributes are: they lock the ankle at 90 degrees. You eliminate the propulsive phase of gait. It redistributes pressure into the leg. We reduce pressure on the plantar surface of the foot. We reduce shearing forces, and this cast is a whole lot easier to take off with a cast saw than a traditional cast. If we do all of this, what we see quality of life issues significantly change for the patient, and then we save tremendous amount of time and money. And I'm not talking about time and money in the clinic. I'm talking about time and money associated with amputations. If you look at the 2-year data on an amputation, the healthcare charges in the United States for that patient is over $90,000. If a patient has an amputation, the lifetime costs of care hover over $500,000. It is minimal investment to use appropriate offloading to heal these patients in a timely fashion, prevent the infections from occurring, and thus the 20% of the patients that get infected get amputations. That's our goal. Eliminate the infections that we can the amputations that we can prevent. So we do workshops all over the country. I love it when we do workshops and the doctors and the nurses are all wearing the cast, so they get a feel for not only what it's like to put it on, but what it's like to wear it. And sometimes they'll wear them for half a day before we take them off. But really, total contact casting, the stigma is not what it was 20 years ago. The TCC EZ with over 300, probably almost 320,000 applications now around the United States, Canada, and over in Europe, really indicate that it's safe to use, it's effective to use. But we need to remember, leaders do the right things. We need to assess these patients correctly. We need to evaluate their vascular status. If it's not appropriate for healing, we need to send them where they need to go so that we can increase perfusion. We need to be able to address infection appropriately with IV antibiotics and debridement and oral antibiotics. Oral antibiotics today are much better than they were even 10 years ago. And there have been studies that show that they're effective for osteomyelitis. So all of a sudden, offloading and keeping the patient on their feet and making progress towards healing becomes paramount. And that's where the TCC EZ comes in. I love to show this picture. My wife and I were down in southern Arizona and we stopped in to have breakfast at Richie's Cafe. And here's Richie. Richie owns the cafe and he's wearing a TCC EZ. That's me in my non-clinic attire, right, with my Green Bay Packer hat. And Richie told me that the TCC EZ cast is the only thing that's enabled him to heal, and that without the cast, he wouldn't have been able to keep his cafe open. So I love sharing stories like that. I see that all the time and I hear about it a lot. So it's just awesome to see patients benefiting from the cast. So thank you. I'm going to stop sharing. And as promised, it took less than 30 minutes. Now we can just have fun discussions the rest of the time. And I look forward to answering any questions that you have. Holy cow,
Awesome.
55 in the chat room, Troy.
We got lots of messages coming in here. Oh yeah, people are coming in from all over the place here. We got some people connecting in the chat there too. And we do have a question that's popped up as well. So maybe we'll start with this one here. This person's talking about they're working in a facility that might have high human resource turnover. Would you suggest that a trained casting tech should be the person to apply the cast? Or what are your thoughts on that?
My gosh, if you can make that happen and you can train a tech who in the clinician's world, you're assessing the patient, right? You're trying to determine if it's right for that patient. Yes, indeed. I used to have a podorthist in my clinic that did a lot of our casting, but I also did a lot of my own casting. So if you have the resources to do that, there's nothing like repetition for getting quality outcomes. And the challenge there is if there's turnover in that cast tech, you got to make sure someone else is trained, right? I mean, we see challenges in clinics all over the United States where nurse managers change, medical assistants change, the instructions for use aren't necessarily followed, right? And so it's important that you maintain an educational process. And Integra does just a phenomenal job of helping provide that, and we can do that. Certainly.
Absolutely. And we want to thank again, Integra was a great supporter of our TCC and our diabetic foot ulcer workshop at our conference this year. And that was a great opportunity for some of our NSWOCCs and SWANs and other clinicians to take a kind of more a hands-on approach to that too. I'm going to ask the next question. You're sort of a two-parter, two different questions here. One question is about how long a person should or can have the cast on. And then the second part of that is post after their foot is healed. What do you recommend people wear after? Is there something post cast that you want to have before you go back to a regular shoe? What were your thoughts on that?
Absolutely. Let's start with the first question, Troy. So when a clinician determines that a patient should have a total contact cast and we apply that, they should come back within 2 to 3 clinic days to have the cast changed, because literally because of the pressure on the cone of the leg, the cast will be loose, and we don't want a loose cast on a neuropathic patient. So a cast should be changed at 2 to 3 days and then weekly thereafter. I think it's also important to know that if there's a lot of exudate and the cast needs to be changed twice a week as the wound shrinks, and it gets less exudate, then you can transition to once per week. But really, that's so important to realize. So your question took us through the lifespan of this wound, right? So you've got the wound, you change it the cast twice the first week, weekly thereafter. The average number of casts to heal wounds, by the way, is 7.2. We've done some research on that. And then what happens, right? We all know that once the patient's fully healed, you know how opaque the wound looks? You can almost see the granulation tissue through the skin. We need at least a week continued to be in that cast and offloaded to enable the tensile strength of that skin to be able to withstand a shoe. Now, I'm recommending extra depth, extra width shoes with custom orthotics, right? Soft, accommodative orthotics. We've seen lots of studies over the years. For example, let me give you a 2-year study out of England. If patients wore appropriate shoes and insoles to protect their diabetic foot, they had a 24.5% chance of developing a foot ulcer, a repeat ulcer in the same location. If they did not wear appropriate shoe gear, they had like an 89% chance of recurrence. So I think it's so important to get the patients in appropriate shoes, but you got to wait at least a week, okay? And then you got to follow those patients up. As you all know, these patients are our patients for life. That the reason they got a wound to start with doesn't go away. They're still neuropathic. They still have bony prominences. Now, I'm an advocate of also surgical prophylactic surgeries to take pressure off of wounds. Case in point, hallux IPJ ulcers. They always recur. But if you can do an easy surgical procedure called a Keller, where you take out the base of the proximal phalanx, the entire joint starts to move so the toe can dorsiflex instead of jamming, creating pressure. There's lots of surgical procedures that can be performed also, but I would always go the shoe route first.
Thank you. And I think that helps answer some of our questions. Again, some other people were asking about what do you do
Yeah.
for the prevention of reoccurrence? And I think
Oh
you
my
touched on
gosh.
that pretty well there. On top of this, we had a couple questions. I know it came up a little bit earlier too. We got another question here about it used in conjunction with negative pressure wound therapy or VAC therapies. Do you want to just comment on that? Is that okay? Is that done pretty often?
Yep, happy to. And that's a great question. So there's two schools of thought utilizing negative pressure. Remember, the goal when we use negative pressure is to enable that wound to fill in with a healthy granulation tissue to the level of the skin, the healthy skin. So I can make an argument that I can put a VAC, for example, or any negative pressure unit on a wound, have that wound fill in to the level of the skin, discontinue the negative pressure, and then start total contact casting. That's what most clinics do. However, I've seen a lot of clinics that take the effort to actually window the cast, put the VAC on, or if they don't window the cast, they put the VAC on and then sneak the tubing out of the cast. And that's easy to do. My recommendation, if you're going to do a lot of it, I would VAC first, follow it with casting after the wound's filled in. It makes it easier for everybody. It becomes an arts and crafts game if you're trying to VAC and cast at the same time, and you rarely will see reproducible results when it's arts and crafts. You want reproducible results. My experience, I VAC first, cast after. I just use them as different levels of healing.
Fantastic. Well, thank
In the
you for
healing
touching.
process, I should say.
Absolutely. We had a couple questions here. This one came up a little bit earlier, and these are about Darko shoes. So for people for even ideal candidates for TCC, but they might be a little bit hesitant, especially due to the casting. Sometimes they go get recommended, or they end up being fitted for Darko shoes. Do you want to comment a little bit about how well Darko offloads or its sort of capabilities?
Sure. I don't want to burst any bubbles around here, but there's never been a study that supports the use of a Darko or post-op shoe for wound healing, even if you've got little plugs that you pull out. And there's two reasons for it. One is there's no redistribution of pressure throughout the lower extremity. And if you actually cut a hole out, you get like window edema. The wound goes in. I love that term, by the way. It was coined by one of my favorite nurses. She says, yeah, it's window edema. The wound pushes through the actual aperture of cutting out a hole or something. Aperture pads have not been used to be successful. It's very difficult because a Darko shoe, not only does it not provide the mechanical redistribution of pressure we're looking for, but the patient can take it off. And we've seen in every study that's ever been performed, patients take off their device if they can. Why? Because when they walk on it, it doesn't hurt. So they'll be at home and they take their boot off and they walk around at home. They don't put it on again until they leave the house, but they think they're wearing it all the time and they aren't. The study that came out of Jordan in Australia just validated Armstrong's study on removable devices. Um, they're removable, so guess what patients do? They remove them. They don't have pain with their wound. If you and I, with normal sensation, had a wound on the bottom of our foot, do you think we'd take the cast off and walk around on it?
No.
Heck no, it would hurt. It would hurt too much and it would never heal and it would get infected. Um, there's a lot to be said for pain. You know, pain is a gift. Like Paul Brand said many years ago, pain protects us from ourselves. But patients with diabetes oftentimes don't have that.
Absolutely. I think it's a good point, and I'm sure all the nurses who are online can definitely resonate with that. With sometimes with their patients not always keeping their their boot on or a cast on as long as they should have been told to, for sure. On that kind of note, here we're talking about the wearable side of it here, but some questions we got here about the use of traditional casts and then the TCC in clinics. They find the TCC easy to be softer and not as hard as a traditional cast. Do you want to maybe just talk about that for a second?
Yeah, absolutely. So I think it's important to realize that when I was developing the TCC EZ, I was using the inside casts with the honeycombs to replicate only the plaster cast in the traditional cast. And then the outside boot for the TCC represented the outside fiberglass of a traditional cast. So yes, you will have the volume won't change, but it will be a little bit softer. That the TCC EZ cast itself is not designed to be used on its own. It has to be used with the device with the paddles that the black outer boot. You fit the cast in, the black paddles grab the cast, and they grab them in a way that the cast and the boot function as one unit. That was one of the hardest engineering pieces to put together because you'd think you could have the TCC EZ cast and you could stick it in any boot, right? And it would work. But what the hardest thing to do was to get the TCC EZ cast and the outer black boot to work together so it was all one unit. And once we got that done, the TCC EZ worked just as well as a traditional cast.
Perfect. Well, thank you for touching on that. And we've got a couple of one person here is just mentioning how can we get this message out to our general and orthopedic surgeons in out there, this in Ontario, but of course everywhere else. And maybe just as a larger comment, did you want to talk a little bit about the multidisciplinary team approach to
Sure,
this? You know, from managing the
sure.
diabetic foot ulcer to how does the nurse play a role all the way up to
Oh
the
my gosh.
surgeon? Yeah.
Yeah. In my clinic, without our nurses, we couldn't function. Our nurses were phenomenal. And nurses are, and all doctors and all healthcare professionals, they do have at their tip of their fingers evidence-based medicine. There's nothing more painful than having a patient that's had a wound for 2 years and been in the hospital 4 times, in and out of the hospital, be referred to your office, and then you heal them and fix everything in about 6 weeks. So I think evidence-based medicine and education is important. Um, I think nurses are our conduit. They're the most passionate about wound care. And if I'm in a clinic and I teach doctors how to do total contact casting, I spend about 75% of the time talking to the nursing staff because the nurses are with the patient. The nurses are garnishing the trust. The nurses are really delivering the care. So the docs just need to be aware that, hey, yeah, docs are great at debridement. Docs are great at infection. Docs are great at vascular reperfusion. Everybody has their place in the multidisciplinary team. The challenge becomes when the infectious disease doc is the main doc, but the ID doc doesn't do debridements, or the ID doc doesn't do offloading, but the ID doc's all over infections, right? So we have to work as a team. There's no way that the patients are going to get the outcomes we're looking for if the docs and the nurses and the podorthists and the medical assistants aren't all working together for the same end. And that goal is to meet the needs of the patient, heal them up and get them being a productive member of society.
Well, thank you for commenting on that. And I know we have Jenny from Integra is in the chat messaging. There's a couple people who are asking about how can we get some more training, how to get some more knowledge about that. Jennifer was just mentioning that they do have from Integra a field training specialist who can help be connected with you.
Absolutely.
Jenny, if I can get you maybe to put your email just in the general chat there too for some of the people who are asking. I know it's been coming up quite a bit, but we will be sending, as I said, a post a webinar email, and if you want to get in touch with us, we can get you in touch with Integra too. But this won't be the last time we provide some education on this topic for sure. So getting back to a couple other questions, we had some people who were talking about when it's appropriate or when it's not potentially appropriate, or what are some risks potentially associated. Some people are mentioning potential risk for falls. We talk about some children with special needs potentially. What are some conditions where you might mention, you know what, you've got to take a quicker or a deeper look at whether you should be wearing this or not?
Fabulous question. I spend more time as a consultant with Integra talking doctors out of using total contact casts than I do convincing them to use it. That sounds counterproductive, right? But I get emails all the time with pictures and texts of infections. And the docs want to say, hey, could we put this patient in a cast? No, you can't. If a patient has an infection, they need to be treated and have resolution of that infection before you can cast. If there's a bone infection, they have to be treated either with debridement and appropriate antibiotics or antibiotics that are approved for bone infections before you total contact cast. Yes, you can treat them while they're being treated, but it needs to be addressed. Second, vascular status. No blood, no healing, right? I mean, that goes without saying. We need to have an effective, objective way that we measure blood supply to the foot. Sometimes the best thing we have is an ABI. Sometimes we have toe pressures. Sometimes we have TCPO2s or skin perfusion pressures. But because of the technology today, Troy, we can reperfuse feet all the way into the medial and lateral plantar arteries. I mean, if there's a blockage, we can open it up and we can get blood down to that foot to heal it. We are doing our patient a tremendous disservice if we're not getting that workup right appropriate. So a total contact cast isn't going to fix the blood supply issues, and a total contact cast isn't going to fix infection issues. So let's talk about other things for casting. Hey, I'm the first one to tell you, everybody needs to put a roof over their head and feed their family, right? There are some patients with jobs, they won't let them wear a cast. And in that case, we have to do everything we can with the shoe. We need to put additional depth to the shoe. We need to carve out areas, apertures, which I discussed earlier. We do everything we can. And I keep those patients on a very short leash. I have them coming into the office every single week to be seen. Because if you don't, they're going to disappear and have a problem. So there are a lot of, there are patients, the fall risk isn't such an issue. You'll be amazed when I tell you this. When patients wear a cast, it almost stabilizes them because you've locked their foot and ankle at 90 degrees. Do I advocate using assistive devices? Absolutely. You should use a cane, for example, a 4-prong cane. There's nothing worse than a cane that when the patient puts it down, it falls on the floor, right? But a 4-prong cane or a walker, get them used to wearing the cast. It's almost scary. When I follow a patient around that's wearing a cast after they've worn it, you almost can't keep up with them because they're used to walking on it. So the fall risk is less than one might think. There's some spastic disorders that I have not used casting on because I was just afraid that the spastic foot is going to put undue pressure at different areas of the foot, for example. There's some real challenges out there. Kids are a challenge, right? We used to have a 2-inch total contact cast tube. Nobody was using it. We don't have it anymore. So if you're dealing with a child with an issue with a wound, you're almost better off just using a plaster cast, right? Just something that you can apply, then you can soak it in water and take it off. Then you're not scaring the young person with a cast saw or anything like that too. So there's ways to work around it. But I'll tell you what, 85% of patients probably can use a cast. 90% of patients.
I gotcha. And you were mentioning there again the importance of keeping it at that 90-degree angle there. Someone was also asking about any tips you might have for ensuring that when you go for
Oh,
the
yeah.
actual casting, ensuring that the ankle is maintained at that
Oh,
90 degrees. Do you want to have any tips or comments on that?
Oh, absolutely. This is one of my favorite topics, Troy, because one of the reasons clinics find challenges with casting is they don't get that foot at 90 degrees. So all the total contact cast studies I showed you on that slide were done casting the patient in a prone position. If you put a patient on their stomach, prone, you bend their knee, you are relaxing both the gastrocnemius and the soleus muscles that conjoin to make the Achilles tendon. So if you're standing next to that patient and their foot's up in the air, their legs in the air and their foot's here, that foot drops right into a neutral position. Okay. So you cast the patient, casket, 2 or 3 minutes after the cast on, they can turn over. They're not on their stomach very long, just a couple minutes. And then the cast can harden and they can leave. Not everybody can roll on their stomach, right? I mean, I've had 400 and 500 pound patients that I've had to cast in a sitting position, but the biggest challenge is getting the foot at 90 degrees. So I've got 2 medical assistants and me, and we're all trying to keep the foot at 90 degrees. What you don't want to do is sit the patient in a chair, force their foot on the ground and put pressure on it to get to 90 degrees. That puts pressure points right on the areas that can't tolerate pressure, and you'll end up getting new wounds. That's a big challenge, right? So my recommendation is you can cast in a sitting position, have lots of help, but don't force the foot to 90 degrees, putting it on the floor because you will pressurize bony prominences. The best way, and I'm telling you this because I put 15,000 casts on in my life, the best way to do it is to roll them prone, roll the cast, get the foot perfectly at 90 degrees, and then you can get them out the door.
Thank you for touching on that. I think that'll be a great discussion point for a
Yeah.
lot of people here who are doing this. Yeah, go
Troy, can
ahead.
I add one more thing to that?
Yeah, of course.
There's a subset of patients that can't get their foot to 90 degrees. Glycosylation of the Achilles tendon and things prevents that. Okay. So if you get the foot as close to 90 degrees as you can, say it's 2 degrees off, slightly plantar flexed, then what you can do is you can put a little bit of a lift, a felt lift in the heel of the cast, of not of the cast itself, but of the black boot. And that will accommodate for that couple degrees of plantar flexion. Makes a huge difference. I mean, I've been doing that for years with traditional cast, but we do it with TCC EZ all the time because indeed there are some patients that can't get exactly to 90 degrees no matter what you do.
Fair enough. And talking about the stuff that's going on under the boot here, we had a couple questions about people who are using the boot in conjunction with a dressing for another wound as well. Have you run into that before as well?
Yeah.
How does the boot work in conjunction with other dressings?
Yes. So there's a couple variables going on here. So if you've got a patient, they come in your office for an initial visit and they have a diabetic foot ulcer and they've got venous insufficiency and they have a venous leg ulcer, VLU, the priorities for the clinician is to treat the wound that's likely to create the biggest complication, right? I mean, when I was in practice, I had patients that had a venous leg ulcer for 40 plus years, but they never lost their leg. Trust me, there's no diabetic patients with a diabetic foot ulcer with that ulcer open for 40 years. They lose their leg first. So you treat the diabetic foot ulcer first, and in doing so, the venous leg ulcer will heal. What happens is while you're not putting active pressure, like typically what we try to do with venous leg ulcers, you're actually not allowing expansion of the tissue. So you're not putting pressure on the wound as we would normally do, but you're not allowing expansion. I've treated so many diabetic foot ulcers that the venous leg ulcer is heals 2/3 of the way by the time the diabetic foot ulcer is healed. So that's one thing. And the flip side of the coin, I wanted to talk about wounds on the lateral border of the foot. Remember when we were talking about 88% of patients heal in 43 days? A lot of people say, hey, Dr. Jensen, who's that 12%, right?
Mhm.
12% of the patients aren't healing. And if, sometimes there's a vascular concern, I get it. And we do our best to get as much blood in that foot as we can. But occasionally you have a plantar flexed inverted foot where the ulcer is on the lateral border of the foot, either the fifth met head or the base of the fifth metatarsal. Those are absolutely unequivocally the hardest wounds to heal. And if what I do for those patients is I put a felt or some buildup of foam or other products on the medial side of the foot to kind of give myself more of a flat surface. And in doing that, the cast will put more pressure medially, less laterally, and still enable that patient to heal. I'm sure our audience today, if we all sat in the room and said, what are the hardest diabetic foot ulcers to heal? They talk about Charcot deformities and they talk about inverted feet with the lateral base of the fifth metatarsal.
Okay, well, thank you for touching on that. And another question that came up during the last question, it was about a weight restriction for the boot. Is there a weight restriction? Have you seen any issues with that?
You know, I think technically in the instructions for use, there might be a 400-pound weight restriction, but here's what I will tell you. The question isn't so much how big is the patient. The question is, can we get their foot, ankle, and lower leg in a total contact cast and allow that cast to be fitted into the black outer boot without undue pressure on the cast? I mean, you could have a patient who's just big and muscular, be 250 pounds, and their foot is big and with the cast on, you can't get them in the boot. If it's too big, even with the extra large boot, sometimes there's a challenge there, right? Or if there's lymphedema component, for example. So there's a lot of challenge there. I think that the ankle is the determining factor. If the ankle area of the black boot with the cast on fits, you can probably go with it.
Perfect. I think this kind of ties into a comment that one of our attendees were making about just remind everybody of the importance of lower leg assessments as well, even before we get to that TCC point there. So I don't know if there's anything you want to touch on lower leg assessments as a part of the whole process here.
Sure.
But yeah.
Sure. I always tell my students, remember, there's three components to neuropathy, right? There's sensory neuropathy, which is the loss of feeling. There's motor neuropathy, which infects the intrinsic muscles of the foot, which gives the long extensors and flexor muscles a mechanical advantage to grip, right? They also, you have hammer toes. That's why you have hammer toes in patients. So they have no feeling, they have hammer toes. And the third neuropathy is autonomic neuropathy. And when patients have autonomic neuropathy, they don't sweat. So they've got dry skin that cracks. And I think it's absolutely essential to have lower extremity dermatological assessment to ensure that cracks, fissures, tinea pedis, other dermatological issues are addressed because they can really become a problem in the face of neuropathy. I'm sorry
Absolutely.
about that long-winded explanation, but I think it's important to realize that even like the motor neuropathy, when the toes come up, where does the plantar fat pad go? It moves
Mm.
distally away from the met heads. Now all of a sudden you've got metatarsal heads with skin, the fat pad's distal, putting the patient all at more risk. So all that callus you see needs to be addressed. We need to do everything we can for shoes and insoles to prevent the callus formation that leads to the wounds. It's an all-encompassing event, right? Taking care of these patients with diabetes.
Absolutely. And I'm just looking, we still got some time here. We have a couple other questions that have come
Sure.
up here. One
Sure.
of them that was coming up was about, you mentioned it a little bit earlier on. We're talking about people who are potentially taking off their devices here. What do you think about the non-removable devices that folks are making non-removable? Are they safe? Are there any concerns with this?
I love it actually. Total contact casting was arts and crafts for decades, right? You're talking about 70s, 80s, 90s, 2000s. It was arts and crafts. Everybody was pulling things off the shelf, little plaster here, little fiberglass there. Some of them use a post-op shoe with the cast, some use a peg. I am all in favor of it. Anything that we can do as a team, a wound care team, that's reproducible in your clinic, go for it. Me making the TCC easy, the whole design was to make it easy on everybody, right? Easy on the clinician, easy on the patient, easy on purchasing. Because, the traditional total contact cast has 14 pieces to it. And so if you go into any general supply in the hospital, you're pulling foam, you're pulling tape, you're pulling uh, foam, the felt, you're pulling plaster, you're pulling fiberglass. And what happens if you don't have one of those that day, right? I mean, the patient goes without. So I'm all in favor of it. There is no, in my experience, there's no healthcare provider that's more passionate than wound care providers. So they get creative, they get artistic, and I support them, and I'm impressed, and I say go for it. But if you can't do that, use a prefabricated system like the Easy.
I gotcha. Well, we thank you for doing it. It's awesome. And one of the other questions we had here, we were talking about making sure we can get our patients turned over to get that 90-degree angle when we're casting there. Have you been in situations where you have patients with DFUs on both feet? And how have you approached casting for both feet? Is
Boy.
walking on both is still effective? How are we approaching that situation?
Yeah. I had many patients in bilateral casts. I always tell a story about one of my a priest patient who he had big wounds on both feet. He'd come in on Mondays after being on his feet all day on Sunday, and I would change both casts. And then he would come in on Friday before he had to have masses Saturday and Sunday. I had many patients over the years with bilateral foot ulcers. One's usually worse than the other, so you can heal that one quickly, keep them in the cast for an extra week, transition into that shoe, and then get the other one healed. Troy, which brings me to another point. There's a misconception that if you have a cast on one foot, you increase the pressure on the other. In fact, it's the exact opposite. When you slow down your gait and there's no propulsive phase of gait, your gait shortens and there's less direct pressure. So that's one of the ironies of total contact casts. Go figure, if you put a cast on one foot, there's less pressure on the other, but it's true. It's totally true.
Perfect. Well, that's a great answer there. And we had another person who was asking about the importance of compliance before applying the TCC. So explain that it needs to continue even after the wound heals. Does this often affect the decision to start TCC? How does the patient feel about this sometimes? Did you want to maybe comment on that?
Sure. Um, there's a difference between a patient that doesn't want a total contact cast, but can be educated into wearing one, even if it takes a couple weeks and a couple rounds of pictures to show them that when they're walking on their foot, a callus rim forms and there's no way that that wound's going to heal. I used to make deals with patients. I'd say, look, I don't mind you wearing this non-removable cast, but to be honest with you, they wouldn't be in my clinic if they hadn't failed other regimens.
Hmm.
So by the time they come to my clinic, I've had a couple patients say, yeah, but my other doctor didn't do it this way. And I said, well, the reason you're here is because your other doctor didn't heal you. I'm here to provide you top level care. And so it's education, right? It's getting trust, it's education. But I've had patients, I'm not wearing a cast. And I'm like, that's cool. I can't make you do something. I said, I'm a surgeon too. If you get an infection, I can take you to the OR. I got access to the OR 24/7. So if someone gets infected, I can take care of them. I like to take care of them before they lose their leg, right? I don't mind doing debridements in the OR. So I think realism and being a realist when it comes to the potential outcomes of a diabetic foot ulcer is doing your patient a tremendous favor. Kicking the can down the road and not healing and not making progress is not the answer. It just isn't. It's not the answer for the patient. It's not the answer for the clinician, and it's not the answer for the healthcare system.
Okay, well, thank you for touching on that. I'm not seeing too many other questions here. We did have one, however, a little bit more humorous question, but we'll ask it anyways as we get to closer to wrapping up here. You're in Arizona now, and I know you did residency in Michigan. How did you become a Green Bay Packers fan? Teresa Henderson asks.
I grew up in Wisconsin.
Oh, there we go. That'll do it.
Yeah. And my wife and I met in college in Madison, and she's from Green Bay. And she loves football too. So we actually have a home in Green Bay still, and we try to get out of the heat and summer of Arizona and go to Green Bay as much as we can.
Fantastic. And I know you're a big fisherman, so I know you're in the right area for it when you go up there. So that's fantastic.
Big time. Yes,
Uh,
yes, indeed.
Awesome. Well, I want to thank you so much, Dr. Jensen. We got through tons and tons of questions today. I know this, so hopefully this won't be the last time we see you. I know we've done a webinar with you in the past too, but we always appreciate when you do come on and provide your expertise there. I'll just remind everyone here as well, if you haven't looked at the chat already and you want to get a little bit more information about Integra's training there, Jenny has put their email in the chat. And again, do follow up with us after from the email you're going to get with your certificates, or email us ahead of time at office@nswoc.ca, and we'll help connect you in the best way we can. But on behalf of NSWOC, I want to thank Integra for being able to put this education on. And again, Dr. Jensen, thanks for your sharing your expertise today.
It's a pleasure. Anytime, just give me a holler. I'll help out any way I can.
Amazing. Okay, have a good rest of the day, everybody. We'll see you at the next webinar for all those tuning in. Bye now.
Bye-bye, everybody.